Good afternoon, everybody, and welcome to our next webinar, which is Near Misses and Incident Investigations. This is a joint webinar with SHOT and the MHRA. So as normal, your microphones will be muted throughout, but if you have any questions, please do pop them in the Q&A box. We'll have 15 minutes at the end of the presentation to go through those questions. Unfortunately, we won't be able to get back to any questions that we don't get to in the webinar, but if you have a burning question, please do email us with them afterwards and we'll follow up as many as we can. The whole webinar is going to be recorded and it will be available on our website as soon as possible afterwards. And we'll also have a live poll at the end of the session. So the format of today's webinar will follow our standard format of 45 minutes for presentation and 15-minute Q&A. First, we'll have Dr. Shruti Narayan, who is our medical director. She'll be followed by Dr. Paula Bolton-Maggs. So we're really lucky to have Paula with us today. She's a previous SHOT medical director and has a wealth of experience as a haematology consultant. She's very kindly this year joined us as a wrong blood in tube expert. So Paula will be going second. She'll then be followed by Jennifer Davies, who's our SHOT operations manager and comes from a laboratory background. Following that, we'll have Chris Robbie, who works with the MHRA. So he's the haemovigilance specialist for the MHRA and also members of the UK TLC and the National Blood Transfusion Lab Managers Group. After that, Shruti will do a little bit of roundup and then we will have time for some question and answers. So I hope you all enjoy and I will hand over to Shruti now.
Thanks very much, Vicky, for that kind introduction. And again, welcome everybody. And I would like to first take this opportunity to thank you all for joining us on this webinar. And also, more importantly, thank you for all the hard and selfless work during these challenging times. And this is on behalf of everyone at SHOT. And the last year, all of us understand has been very difficult for everybody. And we are hopeful that the collaboration, the improved communication and appreciation that has been so instrumental in getting us through these challenges will help build in more resilience and take us forward for a brighter future. So before diving deep into this topic, I think I would just like to actually say, why are we covering this topic? And, all of you will agree, that incident investigations, if properly done, will help identify the correct factors and improve the systems for our patients. But often one of the common recurring themes that we see in our serial SHOT reports are investigations are not being done as thoroughly, as optimally as they should be. We are also not optimizing the learning from these. And also near misses are actually often missed opportunities for learning. And therefore, we wanted to actually highlight some of the principles so that we can actually then say, how do we get to the bottom of these patient safety incidents? How can we identify the contributory and the causal factors? And thereby, you can actually then design the solutions and design the systems so that in the long run, what we are aiming is not just prevent the recurrence of these incidents, completely reduce the incidence of these patient safety incidents and improve patient care as well as safety. And we all are aware that when these safety incidents happen, it can have a wide-ranging impact. So, most of the errors, there may not be any patient impact. But equally at the other end, this can actually result in the death of the patient. So if you're having a wrong blood in tube incident, it can actually result in a wrong component given to the patient. So it can result in an ABO incompatible transfusion, and it can then result in a patient death. So therefore, every effort, it is not, just what the impact it is likely to have. Every effort must be made to get it right first time, every time. And it is also important to just take a step back and understand it's not just the patient impact that we are talking about. Yes, all these things can potentially result in harm as well as patient death. But equally, it can actually have a significant impact on the patient's family as well as the carers. It also has an additional impact on the staff, the healthcare professionals who are actually involved, a cultural impact in the department as a whole, as well as the reputational damage to the organization. And also we have seen where during incident investigations, in those instances where staff have been identified as the sole cause of error, this is also likely to have a negative impact on the culture in the healthcare organizations. And that does not result in improvement to the patient safety. Now, these are the excerpts from a paper in the BMJ Quality and Safety. I've given the link below, which talks about what is the natural history of recovery for any healthcare professional or a provider. This is the additional victim or the second victim after any kind of a patient safety incident or an adverse incident. And all of us can actually understand the different phases. It would be an emotional roller coaster. And in the end, while you can optimize and improve the practices, it can also have deleterious consequences on the individual. And therefore, we need to actually be able to look at how can we make this process, not an onerous, but a learning kind of a process that we actually build into this. Now, there have been several papers highlighting what are the deficiencies in the system. So these are a couple of papers from CQC, opening the door report, learning from harm report, as well as the patient safety, because you can recognize there are several issues that are actually challenging this process, from poor leadership, from poor safety culture, lack of resources, lack of adequate training, because staff who are involved in incident investigations do not always get that necessary training. So what we are trying to address is, yes, we identify these challenges. How can we actually provide the solutions? What are the solutions that we can actually think of? And also, this topic is relevant to all aspects of patient care. This is important in all parts of the transfusion pathway. So whether you're actually staff involved in the blood donor end, or in a blood service end in the processing and the manufacturing, or at the recipient end, these principles are actually applicable for any kind of a patient safety or a quality incident that we are talking about. So over the course of the next 40 minutes or so, what we would be covering are, the safety principles and the key aspects of a good safety culture. We emphasize that, how can we optimize the learning from the near misses? And we will get the insights from both SHORT as well as MHRA. And along the way, we will also be having some illustrative case examples. Now, this was in our 2019 report, and it was also alluded to in our previous webinars. But all of you will agree that the critical elements of a good patient safety culture is that you need to have a reporting culture. And we have a very good reporting culture, but it can also be optimized better. So, you need to have that transparency, everybody willing to share from the incidents, and there should not be a fear of reporting. Equally, it should be a just culture, and I'll come back to that a bit later. And we need to be adaptable, we need to be flexible. We also need to have that learning culture, learning to ask the right questions, and staff feeling empowered to be actually asking and embedding that learning and the questioning culture. So all of these are actually necessary, and these are kind of the elements which actually provide us that index that you have a good patient safety culture. And last year, we also actually then highlighted the safety synergy between the safety 1, which is largely a reactive process, as well as the safety 2, which is a proactive process. And that we actually said that we need both of it. Both these approaches are actually necessary to improve patient safety. So to explain this a bit further, so in our safety 1 is what we routinely practice. It is more reactive. When there's something go wrong, we are actually delving deep to see, okay, what happened, what caused it, where can we actually improve better? But what we are also talking about is safety 2. So this is actually a reframing of safety, and where the basic premise is as many things as possible go right, but you're also constantly trying to anticipate what else can happen, what developments and what events. And therefore, you're seeing the humans as a resource for the flexibility within the systems. So how can we practice this on a day-to-day basis? The safety 2, basically, it's very simply have a debriefing procedure, make every experience matter. So you're asking the question, if after any event, what went right, what can actually be improved, did everybody know what was going on, where were we clear on our roles, what more do we need to do, and what hazards do we actually could we pick up? And I think having that, it's part of reframing this and making sure that that reflexly you're actually learning from every incident, and we need a combination of these. And to truly improve patient safety, it is important that in all healthcare systems, we not just learn from when things go wrong, but also when things go right. And that is why, we have been speaking about it the last couple of years, but we also introduced a new reporting category to SHORT, which is acknowledging clinical excellence, that is SHORT ACE category. We're encouraging that, we are learning from all the events and experiences from excellence, having that principles of an appreciative inquiry. And that helps make it visible, the hidden work that people do to successfully navigate the problems. And this in general, has been shown to build resilient teams as well as the systems. And in the just culture, all of you would be familiar with the just culture terminology as well as the framework. What we are trying to say is, it is important to have that good, transparent and learning culture. And the just culture means that you're stopping judging, you're stopping assigning blame, and you're looking at the whole context. You're identifying the blind spots, you're actually correcting them. It is asking the right questions again. It is a just as well as a restorative culture, and it is about collective responsibility. So we know about those were the elements for a good safety culture. But now moving on to near misses. Now, near misses, by the very term, you will all realize that, okay, these are all the incidents that have the potential to cause patient harm, but they did not cause the harm either because of either chance or prevention or a mitigation. And why is it important? Do we need to talk about the near miss? So reporting and investigating these near misses, they help identify the risks before actual harm has occurred. And therefore, what is happening is they are providing you those opportunities to address the underlying issues in a system and therefore improve safety before actual serious harm occurs. And therefore, in a couple of papers, if you're actually looking at it, they also ask, are these near misses or are they near hits? Because these are actually valuable opportunities for healthcare. And it is, when we look at any kind of a safe building safety in a system, you need to have all combination of all these approaches, a reactive, a proactive, and a predictive. And looking at near misses, investigating near misses comes under this proactive category. When we look at the data from SHORT, it is very reassuring to see near misses have been reported for a long time to SHORT, and more than 30% of the reports submitted to SHORT belong to the near miss categories. So that is the topmost one that has been highlighted here. And this is from the 2019 data. When we look at it in the preceding decade, if from between 2011 to 2019, that still remains the same. So you can see, it's more than 1/3, so more than 35% of the reports are near misses. And in them, the majority of them are the wrong blood in tube incidents, which Paula will be covering in a few moments. So we do have a good reporting culture. We also do a good reporting of the near misses. But what we also need to see is that investigation happening at a local level. And emphasizing the point about how near misses as well as low harm incidents are actually much more frequently occurring. This is the pyramid where you can see that there is only a small number of the transfusion related deaths, but in relation to that, there is a larger number of near misses and therefore more learning opportunities and more instances where we can actually look at the systems and address the gaps in the systems. So therefore, reporting and investigating the near misses would, as I again emphasize, reduce the number of the most severe instances. So there has to be a process. So there has to be a process about how we, similar to what you would be doing with any kind of an incident investigation, you need to have a clear definition about what you're collecting, have that written report, and we also need to actually go through this whole process about when do we investigate, what is our threshold for investigation, and how do we optimize the learning. So elements of a good near miss reporting system would be that it should ask the right questions, as I mentioned, it should have meaningful reports, and it should be thorough. It should identify the necessary safety concerns, and reporting should not be perceived negatively. It should not be seen as a hassle. Staff should also be able to see the value of reporting because it should not be one way. There should be feedback loops. They should be actually also seeing what is the learning that has come through from this near miss learning. And that is not siloed learning. We need to share that widely because if you're actually having near misses in a hematology department, that can actually apply across in the trust in the different areas as well. So sharing that lessons learned is important. And that creates a kind of a collaboration that everybody is in it together. Patient safety is everybody's responsibility, and everybody can actually make that system changes and can contribute towards that. And there should be no fear of repercussion from reporting the near misses. So I'll finish with a couple of specific examples here. So, and all near misses have been picked up basically because of vigilant staff, but we've also had instances where there are vigilant patients and families who would be actually picking them up. So we have this case, these are all from past SHORT reports. So this was an instance where a unit of irradiated platelets was taken to the ward, but the nurse noticed that the component was not irradiated. So, having that visual check in the pre-administration checklist mattered. And the component had been signed and recorded that it had been irradiated, but the nurse diligently contacted the laboratory to actually check because the component had not been actually labeled correctly. And the nurse was appropriately advised to return the unit as it had not been irradiated and therefore preventing the patient receiving an incorrect unit. Another example, this was a case of delayed transfusion where a major hemorrhage call was initiated for a patient with an obstetric bleed, and emergency group O-D negative red cells were not available from the 2 satellite fridges, but that was because there was a need for temperature calibration. but very soon they were rapidly released from the laboratory. And here what had not happened was the communication from the laboratory staff to the clinical staff, so that they were not actually aware that emergency units would not be available from the satellite refrigerators. So it is maintaining that seamless real-time communication, which is very, very important. So Paula, over to you to cover the wrong blood in tube incidents.
Thanks, thanks very much, Shruti. First of all, we'll start with a definition. And so wrong blood in tube is when blood is taken from the wrong patient and labelled with the intended patient's details, or taken from the intended patient and labelled with another patient's details. And a near miss wrong blood in tube is when this was discovered, fortunately, before the transfusion. Next. So this really is just a revision of what you saw before, but we're dealing with wrong blood in tubes 728, or around 700 to 800 each year, near misses. Let's look at the next slide. Now I've picked the year of 2015 because it was a particularly bad year for ABO incompatible red cell transfusions. And you can see that the bottom four were all administration errors, and so was the middle one on the top. There was one wrong blood in tube and one laboratory error. Shruti, if you click, it'll just highlight all that. And the first point I want to make is that 5 of those, the administration errors, could all have been picked up by a proper bedside check, and I'll come back to that a bit later on. However, if we look now at the next slide, we can see that in the course of 2016 to 2019, there were 12 ABO incompatible red cell transfusions, but there were about 100-fold more ABO incompatible near miss events. And so it's really important to analyze the near misses to see what went wrong and how we can learn from those. Let's look at the next one. If we look at ABO incompatible red cell transfusions on the years that I've shown on the slide, what you can see is in the red bars that the error had the potential to be identified at the administration step. And so that's actually most of those could have been detected if the bedside check had been done properly. And that's why SHOT is very hot on advising hospitals to use a checklist. In fact, it should be mandatory so that these would be picked up. Next. If we look at near miss events, this is data from the SHOT report for 2016 because it's got a good graph. What we can see is that most near miss wrong blood in tubes are detected in the laboratory. And that's usually because there's a previously recorded group that's different from the one on the current sample. And what this shows us is the importance of having 2 samples, 2 separate samples from a patient who's never been transfused before so that these can be detected. Next. No, that one, yeah. So when we look at what happened in those wrong blood in tube incidents, we can see that staggeringly, 71% of them were due to either the patient not being identified correctly at the time of blood sampling, and it could be the sample was not labelled at the bedside. That's 71%. And these are 2 basic steps that have been identified as a source of error ever since SHOT started in 1996. Next. So what can we do to prevent those? Well, we have introduced a lot of IT systems in the laboratory that's made lab functions much safer, but of course they only work if they're set up properly and used properly. Next. In the last year or so, some of you will have participated in this survey of the implementation of IT systems. 222 hospitals were surveyed, 93 responded. And you can see the years that the systems were implemented and the different parts of the blood process that can be made into IT, bedside administration, collection from storage or blood draw and sample labeling. But look that most hospitals there have been able to do collection from storage site, but many fewer have done IT for blood draw and sampling and bedside administration. Next. And in fact, we know if you look at, just click the next. Yeah, thank you. That hospitals with all 3 steps, there are only 16 out of those 93 that responded. So that's not a very large number. And that vein to vein electronic process is much safer than not. Next. Because if we look at the wrong component transfused reported by those hospitals, there were 20 and 17 of them had at heart the manual procedures, either labeling, collection or administration. And 3 actually did occur with electronic systems, but that was about collection of emergency OD negs. Next. If we look at the near miss wrong components transfused in that survey, what you'll see there very clearly is that 85% were associated with manual processes. And again, it was with 91% with sample and labeling, and 94% of these were detected in the laboratory, again, showing the importance of having a previous blood group on record. Next. So I'm just going to conclude with 3 case histories to illustrate this. And it's important that this one was department-wide circumvention of the group check policy. A lot of people don't think it matters very much, but what we see here is 2 samples were taken at the same time from 2 different patients. The second sample from each patient was handed to another member of staff and they were mislabeled. And this was common practice in the department, in fact, because the staff had been, although they'd been trained to do it the right way, they felt that this was unnecessary. It was kinder to the patient, because the patient doesn't have to be bled twice and didn't need to stay for the second sample to be taken if they were in the outpatient department. But it's very clearly a departure from safe practice and dangerous. Next. A doctor was called to take a transfusion sample. The nurse provided the doctor with verbal details of patient 1. He or she could not print the request form because there was no available printer and there were no paper forms. So, next. The doctor took the unlabeled sample back to the ward and then mistakenly printed a form for the wrong patient and used those demographics to label the sample. Next. Both the sample and the form were correctly labeled, but the sample taker was able to alert the lab to say it was taken from patient 1, but the lab wouldn't have been able to reject that sample because it was correctly labeled and the details were all correct. So it was lucky that the sample taker realized what they'd done. Next. And this shows the potential errors with computer. During a trauma call, so under a great deal of stress, a doctor sampled the patient and gave the sample to a second person, verbally confirming the name and date of birth of the patient. Next. The second person went to the computer system, interrogated the system and selected the patient record with the same forename, the same family name, and with a 1-digit difference in the date of birth, which was used to identify the sample. So that's a warning. It's actually quite easy to pick the wrong patient off a patient administration system. So I hope that brief overview of what can go wrong will help you understand how important it is to do the processes right and use safe practice. Thank you very much.
Thank you, Paula. So over the next few slides, I'm going to cover an overview of the key principles of investigating incidents. So the aim of any incident investigation, and that's whether it's a near miss or an actual harm event, is to essentially to answer these 3 questions. What went wrong, why it went wrong, and what can be done to stop it going wrong again. And this sounds simple, but investigations are often very thing that went wrong, and they do take time to complete. What went wrong and make assumptions based on your own experiences. So always start with an open mind and a questioning mindset. And why, as in WHY, should become your favorite word during an investigation. So the first things that need to be done after an incident are the remedial actions. And these may well have been done by the staff involved at the time before you as the investigator are involved. Making sure that the patient's safe is obviously the most important thing to do, but you need to think about other patients. Might they be affected as well? And particularly in lab testing instances where multiple patients might be at risk and you may need to recall results and components for other patients. And what about the staff? We also need to make sure that they're okay, particularly in a serious incident with patient harm. You need to look at your service. Does it need to be suspended? Can it be suspended? Or can you continue whilst the investigation takes place? But you'll almost certainly have to put in some remedial actions to make the system safe while you investigate. So this slide gives an overview of the investigation process, and I'll talk through each one in a little more detail in the following slides. So having the right individuals in the investigation team is vital in ensuring that you get the right outcome. The number of individuals in the team needs to be appropriate to the scale of the incident. So you may find you need quite a lot of people for a serious externally reportable incident, but maybe just a few people for a less serious incident. But what's really important is that there are people in the team who are experts in the relevant subject matter. And this will obviously vary depending on whether it's a laboratory or a clinical incident. And at least one member of the team should be trained in incident investigation. The team need to agree how they're going to meet and conduct the investigation, their roles and responsibilities and timeframes for completion. And we mustn't forget the individuals involved in the event as well. They've not intentionally made an error and they need appropriate support from their line managers. But equally, as investigators, we do need to hear their account of what happened. But to be clear, this isn't to apportion blame. And it's advisable to get an account from them, which can be written or verbal, as quickly as possible whilst it's still fresh in their memory. And if you're doing this verbally, then asking open-ended questions and listen to what they say and don't be judgmental. Next, please. Thank you. So there are a lot of different tools that you can use for doing your investigations. You don't need to use all of them all the time. You just need to select the ones that are appropriate for the event. And your organisation may have their own tools, or there are plenty available online. Starting off with a timeline can be a really effective way to establish the facts and sequence of events that led to the incident. And process mapping or policy mapping are also really useful, as they can help identify the failure points and weaknesses within the system, and also help you to understand the system if you're not very familiar with it. But whichever tools you use, make sure that they include consideration of human factors, such as the incident decision, human factors investigation tool. So SHOT developed the Human Factors Investigation Toolkit, or HFIT, that you can access on our website, and it is included in the reporting portal when people are putting in their incident reports. And the aim of this was to identify the causes of the incident, contributory factors, and any other incidental findings. And an incidental finding are ones that may not have impacted on this particular event, but have the potential for harm in other scenarios. And the HFIT drills down to these 4 factors: staff, environmental, organisation, and government regulatory, and how they have impacted on the event. And the SHOT reporters are asked to give these a weighting or score to assess the impact of each one, from 0 to no impact to 10 for full causation. The use of the human factors scoring was reviewed over a 4-year period. And over a third of incidents were scored for a single contributory factor. And the vast majority of these were given a score only for individual staff factors, so putting the responsibility onto the individuals. And over the 4 years of this study, there wasn't a major change in the distribution of scores, as shown in the figure, although the trend was to assign slightly less responsibility to the staff members. And it's really important when investigating incidents to remember that it's all about the system. This is what can be changed and improved. And we need to create systems that make it easier to do the right thing and harder for individuals to do the wrong thing. And as you work your way through your investigation, you will see good practice as well as things went wrong. And it's really important to highlight these, not just in terms of supporting the individuals involved, but also for the learning points that can be used to improve practice and can be shared with others. And Shruti was talking earlier about the ACE category in SHOT that you can report good practice to. And we also see ACE aspects appearing in incident reports, such as the practice during a total power outage in a UK site that's now being shared nationally as a safety notice. So as you identify the failures and weaknesses during the investigation process, these will form the basis for your corrective and preventive actions. And these are the things that you're going to put in place to stop the error recurring. And these should include all causes, contributory factors, and incidental findings. There is rarely a single root cause that needs to be fixed. And the actions that you put in place need to be smart, as described in this slide here. Vague actions with no tangible outcomes, time frame, just will not happen. So in this slide, there are examples of a well-drafted action and a poor action, which have resulted from a finding relating to a failure to respond appropriately to a fridge temperature monitoring alert. And the good action you'll see is very specific in the details of the training plan and the competency assessment. It's got a target date and it's taken into account staff working shifts that need to be trained before they go on their shift. An individual has been tasked with the action and there are details of evidence required to prove it's been completed. The poor action, on the other hand, has very vague details, a rough target date and no account for how all the staff are going to be trained before they work. The action's been assigned to a team rather than an individual, and there's absolutely no evidence to be collected to prove that it's been completed. So it's really unlikely that this action will be successful. But some CAPAs are better than others, and this is known as the intervention hierarchy. The most robust interventions, or CAPAs, are forcing functions. And forcing functions are aspects of a design that prevent the user from taking an action without consciously considering information relevant to that action. And forcing functions may be physical barriers, but they're often automated or electronic, as Paula was talking about. And examples of these are a rule in a laboratory computer system that doesn't allow you to issue ABO incompatible red cells, or blood fridges that are locked by an electronic tracking system. And although forcing functions work really well, they're often difficult or costly to implement, and so they may form the rear guard of any of your CAPA. Systems-focused interventions are reasonably effective, and these are things such as checklists, warnings, protocols. They're usually easier to implement and less expensive, and so they can be used as an interim while you look for forcing functions. Less effective functions are more people-focused, and they include education, training, rules, and policies. They do have their place and they are required, but they do need to be supported by some of the more effective functions, as discussed. So whatever interventions you implement, they do need to be effective. And this slide is a little busy, but it gives you some ideas on how to make the most of your interventions. And you can see these in more detail in our ShortByte, which is on the website. And when you put your actions into place, don't forget that you will need to evidence that they've been completed, because that might be required for some regulatory inspections. But once the CAPA's done and you've put in all your actions, I'm afraid it's not job done. You do need to monitor and review the effectiveness of your actions, and you may need to make amendments to some of these if they're not effective. The way that you review the effectiveness will depend on the type of action, but it might include things like audits, debriefs, risk assessments, questionnaires. The time frame for review is also variable and dependent on whether it relates to a task that's maybe done many times per day, so you can do your review quite quickly, or it's less frequently. You might need to wait longer until you can do that review. And the similar theme here is that sharing the learning is so important, as it can stop similar errors happening elsewhere. And this is sharing not only within the team, but across departments, across the organisation, and wider as appropriate via the MHRA and SHOT. And it's this sharing process, as well as the learning and effective CAPA, that can really improve patient safety. But of course, prevention is always better than cure, and we'd rather not have patient harm incidents in the first place. And that's why it's so important to thoroughly investigate these near-miss events and also have detailed risk assessments in place that cover every aspect of the task or process, that you can take a more proactive approach to preventing error as well. We do need to support a good safety culture, and that's one that encourages suggestions for improvement from everybody, and have a management and leadership that listens and responds as well. Thank you. I'll now hand over to Chris.
Okay, thank you for SHOT to inviting me to take part in this today. Some of what I've got to say is a summary of what's been said before by previous speakers, but also giving some insights in terms of the regulatory practice. If you can go to the next slide, please. So blood safety and quality regulations highlight to us that there's no actual concept of a near miss within the statutory framework. However, you are required to report incidents which may influence the quality and safety of blood. So anything that is reported as a near miss could still be seen as a serious adverse event. Can you go to the next slide, please? We also need to look at the good practice guide that's come out of the Council of Europe and the EU. It's still relevant to the UK reporting picture. And the good practice guide tells us that we need to have a formal system for handling incidents, and that an appropriate level of root cause analysis should be applied during that process. And if you can't identify the actual root cause, then you need to identify the most likely root cause. If you could go to the next slide, please. The good practice guide continues also to say that if you suspect human error as being the root cause, that needs to be justified. You need to have done your root cause assessment. You need to have identified whether there can be improvements to the process, procedures, or any other aspect of the quality system, and take appropriate action. And that is further detailed in section 9 of the good practice guide. And although this will relate to laboratories and blood safety and quality regulations, because it's based on principles of good practice and quality risk management, it can be applied in any situation, including the clinical area. If you go to the next slide, please. So we've already covered a lot of this already today, but we investigate to correct mistakes, identify weaknesses in the processes that we use, make improvements to those processes, and learn and share what we have learned. We need to build improvements to the future of the quality system and ensure that patient safety is ensured by a robust system and safe components created via consistent and safe practices. We're not here to blame individuals for the errors that are made, even though individuals working within the quality system need to take responsibility for their actions. They shouldn't take responsibility for a weak quality system itself. The next slide, please. So Shriti's already made some comments about being reactive, proactive, etc. So in my slides, I said, yes, we need to put things right. We need to take corrective action to ensure that the same mistake doesn't happen again, but your preventive action prevents future and unknown errors. So the example I've used is that a locum has issued non-irradiated red cells to a patient because they hadn't been trained in the process. So the correction was to recall the units and issue the correct units for the patient. Corrective action was to train that locum and identify any training gaps for that individual, but preventive action would be create a system and an induction program to manage the training of all new staff, not just locums. Next slide, please. Again, Jenny has covered most of or all of the reporting process, so we won't cover this in too much detail, but after the errors occurred, you need to assess the situation, control it, put in your correction. You need to document and report, and this is that point that you need to report to SHOT and SABRE, not after you finish the investigation process. We need to know about these things as soon as known, when it's happened. You need to assign an investigator, and again, to reiterate Jenny's point, they as well as being subject matter, they need to be people who have experience of investigation, because somebody who doesn't necessarily know exactly what's being investigated can still ask some pertinent questions. Within that investigation, you identify your witnesses and gather the evidence, and then you set about your root cause analysis and CAPA process. And as well as monitoring the effectiveness of the individual root cause and corrective action, it's important that you trend your incidents at regular intervals. You may not identify all of the root cause and corrective action at that point, but if you trend your incidents over a period of time, you gather evidence to demonstrate, for example, that if you've got a lack of staff or a lack of educated staff, that is actually what needs to be addressed to ensure long-term change. If you go to the next slide, please. Some of the important messages to come out of the reporting process is that we need to document and report as soon as possible, so you have a fresh recall of events and in as much detail as possible. Inspection findings tell us that many investigations are weak because evidence has not been gathered while it's fresh. And it should be done in a timely manner, preferably at the end of the shift, as directed by your documented procedure. Quite often I'll review a report that says we can't identify the root cause the root cause because the member staff has left the trust. If that's the case, your investigation process is weak because it's not getting all the evidence in a timely manner. If you go to the next slide, please. Not going to go through this slide in very much detail. You can look back at it, but it's here to demonstrate that you don't have to apply full root cause analysis to all of your incidents. As I said before, it needs to be appropriate to the level of risk. So major critical incidents will require full root cause, and it may take you a month or maybe up to 8 weeks to investigate and identify your corrective actions. But for observations, including near misses and less serious adverse events, as long as you identify why things have gone wrong, you may not necessarily need to go through a formal trust root cause assessment. And the time frame for putting those corrective actions in place may be just 1 to 2 weeks. If you go to the next slide, please. So this is data from my subcategories that I have produced for my SHOT chapters for the past few years. And this is a breakdown of all the human error incidents that have been reported in 2019. And if you look at the highest 3, the majority of incidents that appear to be down to slips and lapses, procedures not being followed correctly, or correct procedure not being done correctly. So about 43% of incidents are down to slips and lapses. According to this, the rest of the 57% have identified improvements in the quality systems. Now, I believe that we can improve that. We can identify more system improvements with a more thorough investigation of the 43% that come into the slips and lapses category. We have made improvements over the last few years. Recent data is up to about 60% system improvements. But I wouldn't get to that figure if I wasn't asking reporters for additional information from time to time. So it's important to take these messages and to improve the depth and thoroughness of your investigations to identify true root causes and effective corrective and preventive action. I think that's my last slide, so I'll hold a hand back. Thank you very much.
Thanks, Chris. So to round up, I think you've heard from all my colleagues about the importance of a good, thorough incident investigation. But we also recognize that more work needs to be done to improve the incident investigations. We need to also optimize our learning from the experiences. We need to also actually look at all our systems. Are we actually capturing and learning from the near misses as well as from excellence practices? And also incorporate human factors principles into the incident investigations. And a couple of final slides that I just want to actually highlight also some of the resources that are available. This is from the Chartered Institute of the Ergonomics of the Human Factors. They came out with a white paper on human factors, as well as another paper about learning from adverse events. So although I'm not going to go through this figure, but this is actually from that, I would actually request that all of you go back and read that. That actually talks about what are the principles, how you can incorporate the human factors into incident investigations. So it is, how that, the reframing of the questions, that approach, and, avoiding the blame and asking the right questions that underline these principles. Equally, one other point that I wanted to actually go beyond even just this information gathering, is also understanding, is there any bias, both from even an investigator when you're involved in that incident investigation as well. It is important to actually be aware of any kind of a cognitive bias that may be operational. So we have highlighted in the previous report as well about the possibility of an attribution bias even before you start. So somebody who is involved in incident investigation should go there objectively, being able to actually assess rather than actually some preconceived notions. So cognitive biases themselves are also recognized as sources of errors. So not just in the process of incident investigation, it is also important that, in any incident that you're actually operating, you're asking, okay, is this a gap in the knowledge or training? It's also actually, is there a cognitive bias in action here? So one of the first steps in addressing these is actually staff being aware of these cognitive bias, whether it's an assumption bias, whether it's an alert fatigue that is actually happening. So I think it is those additional questions that we need to go scratch beyond the surface to actually then get to the bottom of the incidents. And we do have a resource on the SHORT website about the cognitive biases, so please do access that ShortByte on our website as well. And it's also important that, talking more about the culture as well as the psychological safety is a term that all of you would be actually increasingly hearing in all the different, from a safety culture and a leadership management point of view. And it is extremely important that we need to move away from that psychological danger to a psychological safety. So that, where we are actually learning from the failures, where reporting actually happens, where there is more transparency and where there is more sharing. And I think that is where we need to actually aim to go. And I would also like to signpost, I'm sure most of you are already aware, there is a national patient safety syllabus. This is for the first time, it is actually across NHS, across UK, and this is an NHS-wide patient safety syllabus that has been actually brought out. And this is under the Academy of Medical Royal Colleges. However, this is pan-professional, so it is actually multi-professional syllabus. And it talks about that essential patient safety principles and the training that is actually needed, for everybody who is involved in the healthcare. So please do look at that, and you would also be actually having different patient safety champions or specialists in your trust. So please do link in with them to actually make sure that we are embedding all these improvements in practices. And also we have spoken about, the improvement, how do you sustain the changes, where we have spoken about how do you monitor the trends. So when we look at it, we are not just talking about spreading it within the organization and beyond, also about sustaining the changes. So this is actually an improvement wheel that was, mentioned by, and this is in this publication from the NHS Improvement. And what they recognized is all the different factors that we are actually seeing here, are the factors that would be affecting both the spread of any kind of a change or an innovation, as well as the sustainability. So it is all about that ownership that we're talking about that leadership, about having the access to the resources and the appropriate training. So it is important that, okay, you are addressing these and any of these. So if you're looking at, any kind of these incidents, applying the systems thinking principle, but also looking at it, I don't want this from recurring, therefore what else has to be actually done, and what are the factors that needs to be placed, and creating that momentum of change. And also I like this, illustration, a doodle graph about, what is a progressive mindset, about a progressive workplace. It is actually when all of these, we all are actually having that aligned purpose as well as the values, having safety at the heart of everything that we actually do, maintaining that networks, not a hierarchical system, it is actually more a network kind of an approach. We're having a very supportive leadership and an authentic leadership there. We're also able to actually adapt within, safety limits, having that trust within the relationship as well as within the teams, and having that collaborative decision making that we are having, as well as the transparency, and making the best use of everybody's strengths, and how do you address all the weaknesses. So this is actually where we are going. So I think there's a lot that we can actually then embed into our systems. And as I mentioned that, we have plenty of resources in different formats, in the videos, ShortBytes, and the cars. And if you scan this QR code, you would be able to actually access all of them on our website. And we also, from end of last year, have a Short app, which is actually free to download in any of the smartphones. And that is the QR code from the Google as well as from the Apple platforms. So please do download, and that would give you instant access to all the resources that are available on our website. And we also have an exciting symposium that is coming up on the 14th as well as the 15th of July. Please do sign up for that symposium. That covers a whole range of both hemovigilance as well as patient safety topics. And we have an exciting set of speakers and panel discussions that happen, including a debate. Please do get in touch with us. And these are our contact details by any means: phone, email, Twitter. And we would love to hear from you, and we would want to learn from you as well as help you as well in this process. And in the very end, I would just like to, although it is just a few of us who are presenting, this is completely a collaborative work. And this is actually thanks to the hard work of all the rest of the SHOT team, the working expert group, as well as the wider steering group members, and to all of you reporters, because without those reports, we wouldn't be able to get that learning and the emerging themes. And I would like to thank even our MHRA team as well. We work very closely and collaboratively with them and the UK Forum for Funding. So thank you. And I think we will go for the next 10 minutes for the questions, and I'll hand over back to Simon.
Hello there. That's a really interesting presentation. Thanks very much, everyone, for doing your bit there. We've got quite a few questions coming in and quite a few coming in now as I speak. So I'm just going to go through a couple of them initially and see if we can get some answers to those. So the first question is: a wrong blood in tube that was processed in the lab but discovered to be the wrong patient's blood thanks to the sample taker contact in the lab at a later stage, for example, a few days later, is to be reported under IBCT wrong component transfused? Is it not a near miss unless there was intention to issue blood based on that sample? Is that correct?
Yeah, so Vicky, do you want to answer that? Or
yeah, so in that case, it would be a near miss wrong blood in tube event. So because we've identified that the sample has been taken from the incorrect patient and labelled with the from one patient labelled with another patient's details, no matter how that is discovered, we would class that as a near miss wrong blood in tube, regardless of whether there was an intention to transfuse on that sample. If that sample is being processed and available in the laboratory, it is available for issue. So we would class that as a near miss wrong blood in tube incident.
And IBCT, thanks, Vicky. And IBCT is when an actual transfusion has actually occurred. So that is no longer a near miss. There are already a wrong component has been transfused. Thank you. Thanks,
Vicky. So a really interesting question here. Our trust takes little interest in investigating anything which doesn't result in patient harm, and near misses are no longer reported internally or externally. How can transfusion teams advocate the value of reporting and investigating near misses? Interesting question.
Well, I think I've showed the data for that there are 100 times more near miss events that could have been ABO incompatible transfusions than actual events. So the iceberg is huge, and it's absolutely important to investigate them, because doing it that way is how we've learnt to make the recommendations that have been made in the BSH guidelines about safe labeling and all the rest of it. Yeah, thanks, Paula. And I think I agree with that. And unfortunately, although, all of us would be agreeing here, it is actually, we do still get questions that, there has been some pushback in the trusts about identifying. Now, I think there is a balance to be had here. It is not that we are saying that every near miss needs to be actually then investigated. It is about, that is where we say that you need to have that clear definition and a system, and it is, you should not be resulting in an investigation fatigue. Then investigations just become a tick box exercise. So you don't want that. You need to have meaningful investigations. But equally, when you're actually having, when you're trending and suddenly you're saying that, okay, you're having wrong blood in tube incidents happening, in this new ward that we have, it is important to investigate those near misses, because what you don't want is somebody dying of an ABO incompatible transfusion later on. And it may be actually similar that, and somebody has stripped but not resulted in an injury. You would still need to actually look at it. What was it that resulted in that, or what could have been actually prevented? So it's the same across the patient safety principles. The near misses are providing us that valuable opportunities. And what I would suggest is, I think there is a, from even NHS England, NHSI, NHS Scotland, all of them is the emphasis on improving the learning from the incidents. And so I think there is plenty of evidence that is available there now. So please do use that. And it is about chipping it away and building that right culture and learning.
Thank you.
If I could add a
sorry,
point
Chris.
to that, well, Yeah, so also one of the tools you can use is to go back to the blood safety and quality regulations and the good practice guide. Although that doesn't apply in clinical practice, it applies in the laboratory, and it applies for the safety of blood from collection up to receipt at the bedside. And the responsibility for that is the chief executive of the trust or the responsible person for a private organisation. So, as I've said in my slides, it's based on the principles of risk management. So you wouldn't necessarily want to investigate everything, such as Shruti suggested. But yes, you have the legal backing as well. It's the trust responsibility to ensure patient safety through quality and safety of blood.
Thanks, Chris. I've got another interesting question here as well. The question is, with the loss of the BMS career structures in many hospitals, blood banks over the years, is there any evidence of increased laboratory errors in transfusions as reported to SHOT?
Jenny or Vicky, do you want to start with that?
Yes, okay, I can. Jenny can always add. I don't want to take over, but yeah, we do see evidence of staff coming in that are newly qualified, and then making some mistakes or adding pressure to the laboratory. So obviously, we understand influx of new staff is great. We need new staff to keep for help with career progression. So I get my words out. But you also have to have systems in place to ensure that those staff are appropriately trained and supported during their time in the laboratory. So also consider the grading of the staff that you have available and whether that's appropriate to the jobs that they're doing. Do you've got anything else to add to that, Jenny?
Yeah, just to say that because these new staff need the support and the training, you need to factor that into your capacity planning as well to make sure that you've got the staff to be able to spend the time with those new people and give them the training and the support that they need so they can go on and do their jobs confidently.
And we have just released a capacity planning document along with the UKTLC. And again, that capacity planning document can be accessed on our website under current resources. And equally, I think following on from what Vicky mentioned is also important about, we also see with the lone worker as well, there should be clear escalation policy. So where only single members of the staff may be operating in the laboratory and, often dealing with emergencies and other stuff. Are they actually, as Vicky mentioned, are they trained, assessed, and able to, they're clear about the escalation processes in place, asking for more help as well. So all these factors need to be actually taken in. However, I think, for us, also what I would like to actually say is the challenges are there both on the clinical front as well as the laboratory front. And repeatedly, the surveys are showing us that there is, staffing, both staffing shortages as well as the skill mix, presence of untrained agency staff. All of these are contributory factors. But again, those are system factors. Are we actually resourced appropriately? How do we actually address those gaps? Those are the things that we need to actually use to actually improve and prevent further incidents.
Okay, thank you.
If I could add, it's important that all those aspects that Shruti has mentioned are included within your reports, both to SABRE and SHOT and within your internal incident reports, because without that evidence, you're not going to be able to convince senior management that you're struggling with staff and education. So just because it's going to be difficult to put corrective action in place to deal with those problems, you don't want to hide away from it either. So it's highlighted whether you're struggling to meet your corrective and preventive action plans.
Thanks, Chris. We've got just a couple of minutes left, so I think I've got time for one more question. Sorry, we've not got to all the questions, but we'll get back to you. And if you want to send any questions in via email, you can do as well. So this question is regarding the SHOT ACE chapter, and it's about identifying good practice. From the lab perspective, SOPs are to be followed with a little room for deviation. So is following the SOP to be considered a good practice, and is the staff member involved to be praised for following the SOP? Good question.
So yeah, it's a good question. Now, what we are actually trying to say is, that the SOPs need to be followed. So that is not what we are meaning about learning from excellence in the SHOT ACE. And this is more about, has somebody gone above and beyond? But equally, I think it's about, so in that situation, you're saying that if if people had been deviating from that SOP, asking the question, okay, was the SOP too complicated? Is it not fit for purpose? Is there something else that, you know, people are deviating, and having a reflection instead of people just ignoring those? If that person has actually taken that opportunity to say, okay, this SOP is really having this gap, can we do something about it and address it and change? That is exactly what we mean about, you know, taking that initiative. Now, even though, you know, we say for the short ACE category, you know, please do agree within your transfusion team in the hospital. I think what we want to do is create that ripple effect so that everybody in their local trusts, hospitals, and health boards are able to actually then adopt this learning from excellence. It is not just from following processes. That is not, you're expecting people to actually follow, but you're actually saying about under difficult circumstances, or if you're actually identifying something is not working, then what else are you actually doing, and recognizing that, you know, that excellence practice, and they faced with this situation, but they went like this, and that needs to be captured, and maybe that is something we can actually practice. So I think that is where I hope I've explained it, but if others want to actually chip in as well, please do.
Okay, I think that's it. It's 2 o'clock now, so that's our full hour has been used up there. There is a poll for people to answer. That's going to come on the screen now. If people could answer those questions, we'd be very grateful. Just to give us information. So how are you viewing the webinar? To what extent did you find the session useful? What is your staff group? It's a multiple choice one, that question. Have you downloaded the SHOT app, which is the new app that we have available? And how useful do you find the ShortBytes? These are the ShortBytes that are available on our website.
And while you're answering that, I'll just take the opportunity just to remind you again that we've been recording the webinar, so it will be available online shortly. And thank you for all your wonderful questions coming in. As Sai's mentioned, if we didn't have time to get around to it, please do email us if it's a burning question, and we'll do our best to get back to you as soon as possible.
Okay, so just remains the same. Thank you to everyone for being involved today for the panel, for Chris coming from the MHRA and Paula taking the time to do this. And again, thank you to everyone that makes reports to SHOT. Without your reporting to us, this information couldn't be gleaned, and we won't be able to make these improvements to patient safety. So thank you very much, everyone, for attending. Bye-bye.
Thank you.
Thank you. Bye-bye.